In healthcare documentation, caution feels safe. Words like appears, seems, or possibly sound responsible. They feel careful. They feel protective. But under audit and compliance review, they often do the opposite. This isn't about clinical judgment, and it isn't about whether care was appropriate. It's about how documentation is read once it leaves the clinical context and enters a system designed to assess risk. To explain this, I want to walk you through a real-world scenario, not a hypothetical. This is the kind of sequence that plays out quietly over weeks, sometimes months, before anyone realizes there's a problem. A chart is pulled for routine review, not because of an incident, not because of a complaint, just part of a standard compliance cycle. The reviewer isn't looking for mistakes. They're looking for patterns. They open the first note. The assessment includes language like patients appears stable, systems seem improved, condition possibly related to. Nothing alarming, nothing overtly wrong. On its own, each phrase sounds reasonable. The reviewer moves on. A second note. Similar language. Same cautious tone. A third note. Again, no clear anchoring statement. No explicit linkage between assessment and action. At this point, nothing has failed. No alerts fire. No one is contacted, but something subtle has happened. A question has formed. The question isn't, was care appropriate? The question is, do we understand the decision trail here? Documentation systems don't interpret intent. They interpret structure. They're asking, what was known at this moment? What was assessed? What action followed? When cautious language appears without those anchors, it creates ambiguity without resolution. And ambiguity doesn't stay neutral. It accumulates. Now, the reviewer does something important. They widen the lens. They're no longer reading a note. They're reading a pattern. Multiple entries, similar phrasing, no explicit progression documented. At this stage, no one is accusing anyone of anything. But the system has shifted modes. It's no longer asking, is this fine? It's asking, is this consistently clear? This is where professionals are often surprised, because from the inside, everything felt appropriate. The cautious language was meant to protect, to avoid absolutes, to reflect clinical uncertainty. But the system isn't measuring caution. It's measuring traceability. When the trail isn't clear, delay is inferred, not clinically, but procedurally. And in compliance terms, delay equals exposure. Now, the review escalates quietly. A second reviewer is looped in, not because of harm, but because of uncertainty. They ask for additional documentation, clarifications, context that wasn't needed at the time of care, but is now required by the system. This is where confusion sets in, often frustration. From the clinician's perspective, nothing changed. Care was appropriate. Judgment was sound. There were no adverse outcomes that occurred. So, the question becomes, why is this being questioned now? The answer is uncomfortable, because the documentation never clearly showed how decisions connected over time. The cautious language didn't cause the problem. The absence of structure did. Once a pattern is flagged, it doesn't disappear quickly. Future notes are read more closely. Thresholds lower. Escalation becomes easier. Not because of distrust, but because clarity hasn't been demonstrated consistently. This is how exposure grows without a single dramatic moment. No incident and no complaint. Just repeated ambiguity that was never anchored in a visible decision chain. This is why training often fails to catch this, because professionals are taught how to think clinically, not how systems evaluate records over time. Intent doesn't carry weight in audits. Patterns do. And cautious language, when unstructured, creates patterns the system can't resolve. This isn't about writing more. It's about what the record signals when it reads without you present. In the follow-up, I'll walk through what happens once this pattern has been noticed, and why vague documentation begins attracting attention even when care decisions remain appropriate. Because once the system starts looking, the rules change.